Introduce Moritz Thiel, Dr. Moritz Thiel. He's from the University of Cologne, he's a pediatric neurologist, and he will talk about the results from GNAO1 Registry in Germany. Thank you.
Thank you very much, and thank you for the committee for inviting me here and that I have the possibility to speak to you today. You have heard already some results from our deep brain stimulation cohort, and I'll focus on the other parts that we have seen in our cohort. First of all, just a quick slide of our methods. So in Germany we have a network in which the pediatricians and pediatric neurologists are part of, and it's possible to launch the trials like this over this network. It's called SNEC, and therefore we can inform the pediatricians about the new trial, for example in this case GNAO1, and they can report at first that they have a patient, and afterwards we can contact the patient themselves or they are recruited through the pediatric neurologist. Therefore it was quite easy for us to be able to find so many patients in Germany. We had a Red Cat-based online registry, and we started in 2020 with the recruitation, and it's still ongoing. So for the moment there are 27 patients in our cohort, and as said before, also in our cohort the initial manifestation was very early. So nearly 90% of the patients showed some symptoms in the first year of life, and as was said before, muscular hypertonia was the most seen symptom in the first year of life. So this is a quick overview over the symptoms in our cohort, and I just want to highlight two things here. So the hyperkinetic crisis was really present in our cohort. So 13 patients had hyperkinetic crisis. I'll go on to more detail later. And as you see, nearly all patients showed muscular hypertonia. This is a slide to compare the symptoms with the previous published cases. And maybe it's important for us as clinicians to conceal the parents, because that's what's our job, to tell them what they have to expect. And I think it's important to know that the speech impairment is really also a really big problem. It's over 90% showing some speech difficulties, as mentioned in the talks before. So on the one hand we have the symptoms and we can conceal the parents, but the question is, there are so many different mutations, and there are two phenotypes described before. On the one hand, the developmental and epileptic encephalopathy phenotype, on the other hand, the movement predominant phenotype. And we thought maybe it's easier to show that's the primary protein structure of GNAO1, and we highlighted on the upper part. We assigned these two phenotypes. On the upper part, you see the variants that are connected with the epileptic encephalopathy, and on the lower part with the movement predominant phenotype. But as said before, in the group of France, there are mutations that doesn't fit in this. This is maybe a quite old view that only two phenotypes. And as you can see in this picture as well, there is no special location with only one phenotype. They are distributed really completely over the whole protein, as you have seen. And so I highlighted here some of the milder phenotypes, and I'll also show you one very interesting pedigree of one family with this frame shift mutation that you have seen here on the right. So this young boy was first showed symptoms when he was 3 years old with 2 prolonged febrile seizures, and he had a little motor developmental delay and a severe speech developmental delay. He was treated with the physiotherapy and speech therapy, and now he's 7 years old. He goes to school normally, and he didn't show any movement disorder symptoms until now. Interesting in this case was that the mother of this index patient showed the same symptoms when she was younger. She had some Rolandic epilepsy, and had also a severe speech delay, but she had a mild learning disability. And therefore, she was also sequenced and showed the same variant in GNAO1. And the grandmother of the index patient didn't show any symptoms and had a normal GNAO1 variant. So this is quite interesting, and I think it's one of the main reasons what we see here in this really great conference, that the spectrum will be more. And maybe there's more than only just movement disorder and epilepsy. And this is maybe one case. But for us as clinicians, things we know is that what is really dangerous for the patient is the really critic hyperkinetic crisis, and that's what I'm going to focus now on. This is a short slide that shows on the left side that the patients that had one hyperkinetic crisis, it's possible that they have more than one crisis. And we defined, as you said, asked the question before, what is hyperkinetic crisis? We said it must be really more longer than hours of severe movement without sleep, with fever. That's for us hyperkinetic crisis, but a definition is not yet drawn. But in this case, most of the patients had to be admission to the hospital. And the mortality of this hyperkinetic crisis is high. Everyone, as the clinicians, know this. And so what is important for us is to somehow early detect this. When does it start? And to conceal the parents what they have to see. What is a hyperkinetic crisis? When do they start? And give them an emergency plan, but also emergency plan for the hospital, because most hospitals never have seen hyperkinetic crisis because the patients are all over Germany. So I think that's one of the main focuses that we as clinicians should focus on and avoid the triggers in the patients, if possible. And Jean-Pierre is going to have this topic after my talk, so I'm really curious what he has to say about this. So in general, you have seen the mortality rate. Some other talks also said it's quite high in GNAO1. So we had 4 patients deceased in our cohort, and the question popped up for us, is the hyperkinetic crisis a risk factor for early death in GNAO1? Because 3 of these 4 patients had a history of hyperkinetic crisis and 1 died in one severe hyperkinetic crisis. Of course, that's too small numbers to make any conclusions yet, but I think it's a question that we should follow in the future. Nearly all patients get MRIs, but as you see, nearly half of the patients showed normal MRIs, and the pathologic findings that are marked here are rather unspecific. So as a clinician, I have to say, maybe in the future we have to expand our imaging and use the new methods as told before, and this will reveal maybe the pathologic findings of previous MRIs that were found as normal or unspecific. Of course, the question is, do we get to the point that we can predict the phenotype if we just have a new mutation? This would be great for parents to say, okay, it's a new mutation, but we can tell what to expect. And so we tried different methods that were freely available in the internet to try to predict some models. I'll just have a quick overview for you what we did. This is an example for 2. There is a program called Dynamite, and he can predict if the variant leads to a destabilization of the protein or if there is a structural damage. That's MIS in 3D. So as an example here, I can show you this 3 variants, all at the lysine 46, and you can see the phenotype is clearly completely different. So it's a mild phenotype, a movement disorder predominant type, and a very severe phenotype in this last patient that was published by Young et al. In 2021. And in this case, the destabilization was higher the worse the phenotype was, and the structural damage was also worse. So at first you can think, okay, that's maybe a good idea to do this in silico prediction model. So of course we modeled all and tried really all in silico prediction programs in the internet that we could find, and there was no overall correlation. So there were really severe phenotypes, and it's insufficient yet. But as I've heard, being here at this conference, maybe we'll get to know with some new technology, with great computer rising, it's possible at one day. It would be really great for all of us. But for the moment, it's, I think, insufficient yet for the unknown genotypes. So the question is, how do we get to this aim? Genotype phenotype is important for us, and for the moment we have the base, the registries and the natural history studies. This is the base, and on this one I think we have 3 big columns that we should focus on. It's the biochemical and cell biological methods, the animal and disease models, computerized disease models, and genetics. And of course we should not leave the aim out of focus. We should focus on treatment strategies because that's what's important for the patients. And we have to work together to build up this building that it can stand so long. And the treatment strategies afterwards have to be tested in our cohorts. So to come to my conclusions, so the 2 distinct phenotypes should be replaced with a continuous phenotypic spectrum. The milder phenotypes, as said before in the group of funds, it's a conclusion that it's primarily an underreported disease and that the phenotypic spectrum will expand furthermore. And next conference, maybe we'll have a new phenotype that we don't know yet of. And for the moment, the in silico prediction programs that are freely available are insufficient, and the normal conventional MRI is unspecific in GNAO1. And we as a clinician should focus on the prevention of hyperkinesic crisis because that's what kills the patient. So what's our future perspectives? As said before, we need larger cohorts, and that's why we're focusing with some partners that are here. I'm really proud that we had a really great project submitted last week, and we're trying to have a European natural history study in the European Joint of Rare Diseases, and hope to have a really big database for all our European patients. And to improve the treatment, we're focusing at least on this case for zinc testing in our GNAO1 patients. And as you see, Vladimir Katanaev will present this afternoon the disease model, why we think that zinc is going to help the patients, and how we want to realize this project. So I want to thank you all for your attention, and special thanks, of course, to my great mentor. Without her, I wouldn't stand here. Thank you, Anne. And for further details, here's our publication that is just timely before this conference being published. Thank you very much.
Thank you, Moritz. This is very interesting and also a lot of thinking for the next future. So 2 questions. So I have one question, because in fact you show the MRI data.
Yep.
We knew, from the beginning the MRI is, not really important, but you show that there are, although a specific finding is almost half of the patients. So I think we should change our view. MRI actually is important, and I think if we collect, because we have abnormality in basal ganglia, abnormality in myelinization, abnormality in the corpus callosum. So I think the idea to look deeper into the MRI feature, even not with the new technique, but the standard, will reveal a lot of insights, and maybe we can correlate the severity of the phenotype with some MRI changing. That's something that we have, of course, to deal. What do you think?
Yeah, I totally agree with you. I think just for getting the diagnosis, because sometimes it's like we get patients with developmental delay, and one of the first moves is to perform an MRI and to see what's the problem. And I meant rather unspecific, because you can't find, if you have just an MRI, you can't say, okay, that's GNAO1. That's what I meant with unspecific. But the others, I agree completely with you.
Yes?
I have a question about the brain atrophy, which you see in some of the patients, so a related question. Well, the question is actually general. Do you think the brain atrophy, which is seen in some patients, is the primary feature of the disease, or is it secondary to epileptic crisis or hyperkinetic crisis?
I ask myself the same question when I have seen the data, and I can tell that I didn't go into detail now, but we have patients that had multiple MRIs, also because they got deep brain stimulation afterwards. And normally it's like this: if they are born, the MRI is completely normal, and somehow there must be some kind of destroying parts that, because the atrophy is sometimes diagnosed later. But we couldn't go more into detail. But this convinced also what you said before. There must be some kind of
Yes,
harming parts, and maybe it's the epileptic encephalopathy showing like this.
So I don't think we can say for sure the atrophy is a consequence of the crisis or the epilepsy, because we have a lot of examples of patients with other causes. We have epilepsy and status dystonicus, and you don't see the atrophy in the follow-up. So I think it must be something that is related to the etiology of the disorder. Yes? So the last two questions.
So you're talking about MRI improvements. Is it something that will take place in the next months or years? Or is it a dream hope of yours that will take place in 10 or 20 years?
So actually, if our joint program for the European study will go on, we'll have perfectly imaging quality, and maybe we can show more details in 3 years. In this trial, one part is to focus on this imaging and want to look for it.
We're scaramantic. Okay. So Gali?
Thank you, Moritz, for the great presentation. I was wondering regarding the patient you presented with the mild phenotype and the Rolandic epilepsy. So did the epileptiform activity increase during sleep?
Actually, no. It was all the same. It was not related to sleep. No, it was just the same. But I can only talk to of the index patient. I haven't seen the EEG of the mother, actually.
Okay, thank you, Moritz.
Thank you.
And we